I was walking through the fix department the other day and I saw this case, and it looked just a little odd in the box, so I had to take a little closer look at it to see what was going on. And I'm not, I don't want to sound like I don't feel sorry for the doctor here, because I know that this had to be a frustrating case. When you look what we received here and you look at all the different impressions that this doctor took. So we've got two full arch impressions, and then we've got three quadrant impressions, and it's actually a good sized case. He's got 8 units here that he's prepared, as we'll see when we look a little closer at the models. But just to look at the impressions first, and maybe the reasons why there needed to be so many impressions. I'm okay with a tray like this, a stock plastic tray. I use all custom trays, but I cheat a little bit because I'm practicing inside the laboratory. I realize if you could snap your fingers and get a free custom tray like I do, I don't pay for them, that you would do it as well. So all I can tell you is that I get good results. Some dentists will take the next step and make them in their own office or actually ask for them, but when I was out in private practice, I was using trays like this all the time. And as long as they fit well, and this one appears to, great, no big deal. But I noticed that there really doesn't seem to be a lot of retraction going on. As we zoom in a little bit and look at some of these margins of these impressions up close, hopefully I know I do at my lectures, I really try to have dentists kind of drill into their mind what an ideal impression will look like. In fact, we'll throw up a picture of one right here so you can see what an ideal impression looks like. And what it looks like is it's got material, a fin of material beyond the margin. We have to be able to see some material beyond the margin, and if the end of the impression is right at the margin, that is not going to be adequate. And so when I look at this, I notice that. I also notice just the one viscosity of material. I don't think that's that big of a deal if you pack cord. I use that 2-cord technique, and frankly, I think one viscosity, I think I could get decent results with just heavy body with that 2-cord technique, because you have a huge sulcus that you could drop your car keys into. And again, that's not skill on my part. If anything, it's discipline. It's the discipline of doing the 2-cord technique, and it's letting my assistant, get in, hop in, and do some of the cord packing, which she's allowed to do in California. But when you have a sulcus that open and that wide, there's no doubt you're going to be able to just get any impression material in there. If you're going to use something without retraction, that's when you're going to want to use, an extra light body. Not that I even believe that works. I really don't think there's any material that's thin enough, and I don't think you can generate enough force with this heavy body stuff to push impression material subgingival, to push the tissue away from the tooth and really to be able to get in there. I think you need a clean, dry sulcus. Most of these materials are hydrophobic unless they're polyether, and this might be a polyether. But I still don't think you can generate enough pressure to really get it down there compared to that 2-cord technique. I've tried it. I've tried the different techniques. Frankly, looking for shortcuts, looking for an easier way to do it, and haven't seen them. So those are kind of the impressions, and 5 of them I know is super frustrating for that doctor to have to do. Also, not a big fan of wax bites. This doctor is in the eastern United States, and so these were flown across the country, and we definitely see distortion. Now, he did make it nice and thick. I appreciate the fact that they're nice and thick, because they're much less likely to distort when they're thick like this. It's when we have one single sheet that it's a little difficult to do, but the patient sometimes has a hard time closing into this thicker wax. So if you're going to do a wax bite, this is the way to do it. You can see how many sheets are rolled all the way around there, but we feel much better with something like a Blue Moose, a very stiff polyvinyl siloxane, or my favorite, the Luxabite, which is actually a bisacryl, like a tempering material, and that you can hit with a hammer and it won't break. So we're always a little bit worried about the wax distorting, especially when we have 8 preps, and that gives us, fewer teeth to be able to hand articulate the models with. So, but we were able to mount the models, and when we look at the mounting itself, it appears that it is correct. As we look at how everything lines up here, we feel like, yeah, that's pretty close. But it would be nice if we could, have something a little harder, like a bisacryl material. So now let's take a look at some of the preparations here, since we've seen the impressions, and see if we see any signs of tissue retraction. And you can see some signs of where we went in and tried to trim stuff looking for some of the margins. That's a burr mark. But when we're looking, or even over on this side, for signs of retraction, signs of a wide open sulcus where we could get material beyond the margin, we don't see a lot of that. And by the way, these marks, I'm sure you know as well as I do what those are from. Those are from removing the old crowns that were in place. And I only point this out because this is something that is kind of a big deal for Bruxer when you're removing Bruxer. And the doctor actually has requested Bruxer crowns here. And when you're cutting through Bruxer, you want to make sure that you've got some zirconia optimized burrs. We sell some here. Axis has some burrs, and so does Brasseler. You just want to make sure you're using zirconia optimized burrs, and you want to make sure you're not putting a lot of pressure down on here. In fact, I usually start over here at the junction of the buckle and the occlusal, and I'll take the middle third of my burr. Let's just pretend this perioprobe is a burr. And I'll take it, the middle third of the burr. I won't use the tip, and I won't go to the gingival. I just start right here at the thick part of the crown, and I just go back and forth like this. In fact, we have a video online of me cutting off a Bruxer crown. I go back and forth until I expose a little piece of the tooth, a little section of the tooth through the crown. So I just keep going back and forth, taking it off till I can see that little piece of tooth. And once you've established the depth of the tooth, then I kind of start to unzip it. And so I'll go from that spot and start rolling it up, because now I know I'm down to my depth. And so I keep rolling it until I can see tooth structure. And then I roll it down this way and start pushing it towards the gingival, pushing the tip of the burr down as it's moving once I've exposed the tooth. Because otherwise, if you just lean on the Bruxer and try to cut through it, as you cut through it, it's such a stiff material that as you fall through the Bruxer, you could go into the tooth and leave grooves like that, and we try not to do that. It still happens from time to time, regardless of what you're cutting off. I always turn to my assistant and I say, I've decided to place an anti-rotational groove in the tooth. And she looks at me like, no, you didn't. You just kind of lost control of what you were doing. But how is she going to prove it? She doesn't know what's going on in my mind. And then we look here as well, and again, you can see, some separation in a spot or two where maybe there was cord, but you can see there what looks to be tissue that's been coagulated with an astringent. So we can kind of see the margin most of the way around on those two teeth, and then it gets a little sketchier here on some of these preparations on the upper teeth as well. And so if we look together to see how we did in terms of reduction, well, that's plenty. That is plenty for Bruxer. That's actually enough for Emax as well. So that's a great job on reduction done by this doctor. And yeah, that's 1.5 millimeters, 2 millimeters, and 1.5 millimeters there. So that's plenty for Bruxer. Those restorations will last a good long time. And then, of course, we have a ton here where these two teeth were prepped, and Bruxer's fine with that. And we have enough on the 2-bys. Little tight here. Obviously, to me, this is out of my comfort zone for Emax on a tooth like this. But Bruxer, we've got close to 1 millimeter here, and maybe a little less. But Bruxer will do fine at anything thicker than, I like to say, 0.6 millimeters. Most of our advertisements will say 0.5. I say 0.6 because I have a 0.6 millimeter depth cutter on my burr kit, so I can accurately establish what 0.6 millimeters of reduction actually looks like. So great job done on the occlusal reduction there. And considering that's the #1 problem that we see in the laboratory, it's really nice to see a doctor prep 8 teeth and have enough reduction on all of them. So if anything, to me, as I look back at this case, and we're going to need a couple more new impressions to get started here so we can clearly see the margin. To me, this comes really down more to the impressions itself. The preps, the occlusal reduction, nothing wrong with those. Those are all going to work when we can see the margins. And if you hate packing cord, I get that. It's not fun. I always pack the first card. I pack the 00, then my assistant puts the 2 cord on top of that when I'm out of the room. But if you don't like packing cord, I get it. I understand it. And especially on a case like this where all the teeth are posterior teeth. But that's a perfect time to hop in with a diode laser. And now you look at something like the Picasso Light from AMD Lasers. It's just barely over $2,000. And you can just go in with that laser and just take that diode laser and just zip around the teeth and trough those teeth. It removes some tissue while you do it, but that's really not a big price to pay in the posterior. When it comes to anterior teeth, I'm much more hesitant to use troughing, laser troughing in the anterior, because as you go in, this tissue is so thin right along here that as you go into trough in that area, you actually lose some height, and I re-expose my margin again. But teeth like this, like these 3 teeth and these 3 preps over here, just grab that diode and go in there and just remove that tissue. As soon as you remove that tissue, it looks like you were using the 2-core technique, because you've got a wide open sulcus where you almost can't help but get a great impression. So I get not wanting to pack cord, but if you don't pack cord, you got to hop in there with a diode laser and do something, because just trying to force 1 viscosity of material, or even 2 viscosities of material, even if there was some extra light body in here, it's just difficult to force it down into a wet sulcus with a hydrophobic material. So got no problem avoiding the cord, but you're going to want to grab that diode laser. And really, as soon as this tissue's cleared up from around these teeth and we get a good impression, this is going to be a great case for this doctor, because the preparation looks really nice. So again, only critiques here would be on the impression technique itself and the bite registration. Even though it appears to work here, if you're using a distance laboratory, which would be anybody you're sending it to, whether they're on the other side of the state or the other side of the country, I feel a lot more confident with the more stable Luxa Bite, or you could certainly use the Blue Moose material as well. So hopefully when we get the new impression back from the doctor, we'll be able to see all those margins very clearly, and we can go ahead and help this doctor and this patient end up with a successful case.